Hi, I'm Антонио Stecco. I'm a medical doctor of physical medicine rehab. I'm assistant professor in New York University School of Medicine. I want to present the local reflex pain and how fascia and visceral fascia in particular can be the origin of this problem. With the information that you have collected over time about fascia, in particular about deep fascia, you can manage very well musculoskeletal pain. You can manage very well complex pain that occur with complex motion, like with athletes, with movement that doesn't fall like the typical tree plane in the space. You can work very well in disorder related to proprioception, so ankle instability, everything that is related maybe to dysfunction of the retinacula. But still, you'll be in trouble sometime to figure out what is wrong in some patient. Why is that? Because some symptoms are not classical symptoms related to musculoskeletal disorder, but they can have visceral origin. So keep in mind that there is a continuity between the visceral fascia and musculoskeletal fascia. So if we look at the abdominal wall, we have the three muscles, each one with an epimysial fascia. Below the epimysial fascia, the transversus muscle, we have the transversalis fascia, and right under that, we have the parietal peritoneum. It's important to remember that the innervation of the transversalis fascia and the innervation of the parietal peritoneum is metameric. So the same nerve that innervate the wall, so the muscle, the muscular fascia, innervate also the parietal peritoneum. This is why parietal peritoneum can generate a high intensity, high specific painful afference, something that cannot be done by the nerve that come from the visual organ, because as you can imagine, the visual organ, the nerve have to go through very, particular, unclear, not specific path. So you cannot really define what is wrong in your abdominal organ because it's not well organized, the innervation. It's not such metameric that allow you to really define that, I have an alteration of the upper lobule of the liver or the lower part of the liver. Cannot be done because it's not metameric. So you don't have the possibility to represent clearly in a map in your brain the origin of that afference. At the opposite, this can be done when the afference come from the wall, come from the stimulation of the parietal peritoneum. So that is why if you have a stimulation of the parietal peritoneum, you can say, oh, I have pain, it's a shooting pain at the level of the liver. I have a shooting pain at the level of the spleen. But doesn't mean that it's the spleen that is generating the problem. It's something that is stimulated the parietal peritoneum. And lucky for us, a lot of time it comes from the abdominal wall rather than visceral organ. So think about when you're running and you feel like a shooting pain on the side of your abdominal wall, and you believe that your liver is not doing well, or your spleen is squeezing for give you your blood. This is what the people tell you about this. In reality, it can be just the sliding between transversus and obliquo-internal when you're running to generate exceed amount of friction in the transversalis fascia, parietal peritoneum. So you irritate the parietal peritoneum, you generate an afference that is interpreted by the brain as a visceral region, but in reality is a parietal, abdominal wall or region that can be treated and fixed much easier. So this is a critical concept that has to be taken into consideration because, lucky for us, we have a lot of symptoms that come from the wall. But it's true, you can have a real referring pain from the visceral organ. And as you can see in this picture, but you have a lot of this picture in other books, the size, the extension of the referring pain from the organ is very different. It doesn't reflect the extension of the organ. You can clearly see right here that the kidney have the widest representation of the pain in the surface. At the opposite, like the small intestine, is very little the referring pain that can occur, they can appear in the surface. It is kind of strange because a small intestine is a large organ. Kidney is a relatively small organ. So why there is such a discrepancy, such difference between the size of the organ and the extension of the referring pain? Well, the answer is pretty easy. The answer is that as stronger is the connection between the visceral organ and the musculoskeletal system, as wider will be the representation. We know very well that the kidney is, the fascia of the kidney, the gerota fascia, is fused with the fascia of the quadratum lumborum, with the fascia of the psoas. So this will make that when you have an alteration of the kidney, there will be a huge radiation going down in the, let's say, lateral sequence, a huge radiation going down in the anterior sequence through the psoas. So this is exactly the manifestation of the tension of the kidney. It can go through the quadratum lumborum, lateral sequence, through the psoas, anterior sequence. At the opposite, small intestine is very little correlated with the musculoskeletal system. So the referring pain can be very minor, just like at the diaphragm level where, you know, of course, duodenus is retroperitoneal and the tension can be transmitted. Or let's talk about liver. Liver, it can pull in the suspensor ligament, falciform ligament, central tendon, mediastinum, and so it can generate this kind of spreading pain that can go in the back, where, of course, there's a connection. Lung have a lot of suspensor ligament that can generate referring pain in the neck, okay? So this representation will be different, not just between author, but also between subject, because you will see that some subject, for instance, doesn't have a heart attack that go down to the arm, but a heart attack that go up to the neck. And you will see that sometime during the life of this patient, the like angina pectoris, sometimes is in the arm, sometimes in the neck. Why is that? Because probably maybe after whiplash, instead to have the typical angina pectoris go down to the arm, instead to have angina pectoris go up to the neck. Because the radiation in musculoskeletal system occur where there is more stiffness. So this is the anatomical continuity between the arch of the aorta and then subclavian artery and then middle intermuscular septa. So this is like the first highway where the tension of a heart that doesn't squeeze exactly in his axis will generate a stretch of the aorta arch, and so spreading pain in the intermuscular septa where the artery is merging in neurovascular sheath. But anytime that you start to have a stiffness in other part, it can affect the way that this tension can be spread, the way that you irritate the free nerve endings. So this is why releasing the tension of the container, it can improve the mobility or motility of the organ and decrease this severe visual somatic pain. But at the same time, you can do vice versa, because if the muscular system is very tight, it can affect the mobility and motility of the organ, and so generate dysfunction. Let's give an example. So you have a patient that comes to your office for knee pain on the left side from 4 months. It can be, it's always there, even at rest, okay? Look, during the night, it gets worse. So what is the region of this problem? And then you figured out that he had a kidney stone 1 year ago. So kidney stone is still a trauma, and kidney stone can lead to stiffness in the visceral fascia, and this stiffness from the visceral fascia from the renal fascia, can go to the prevertebral fascia, retroperitoneal space, pelvic fascia, the fascia of the obturator muscle, the iliac fascia, and go down in the fascia lata, and so reach the knee. So you can have a referring pain, a visceral somatic pain due to a visceral origin. But don't forget, it can be also vice versa. You had a major trauma in the knee, major, has to be really major, with a major instability, and over time the patient starts to have a recurrent kidney stone. Because the tension from the knee can compensate over time above, it limited the mobility of the kidney, so the sand can have retention of the sand in the kidney and stimulate the production of kidney stone. So it's much easier the way visceral somatic is much faster. Somatovisceral is when you have already run out the possibility to compensate in the musculoskeletal system, then you start to compensate in the visceral part. So don't forget that a lot of time musculoskeletal symptoms are just the peak of the iceberg of important visceral problem. So the patient comes for a neck pain, and then you find out that there is a reflux, food intolerance, gastritis, a lot of other problems going on. So if you don't have a clear origin of the problem, just take in consideration that maybe it has a visceral origin. This is quite simple to understand because we have a lot of connection between visceral organ and the wall. We see the round ligaments, the suspensor ligament, the falciform ligament of the liver, but there is a lot of other connections that are not well described in literature and are not pathological yet. Okay, of course, adhesion will make everything worse. So think about, for instance, the sternopericardium septa. Okay, so this structure here can be very tight. It can transmit the force from the sternum up to the esophagus. Have you ever tried to swallow a big piece of meat and you feel like a knife going down behind the sternum? What is that? Is a increased stiffness of this structure. So when the food goes through the esophagus, it pulls this structure and you feel pain where? Where the tension of the fascia reaches the musculoskeletal system that has a much more somatic afference. So you don't feel this tension, but you feel like a kind of enthesitis right here. Or you can feel the tension like a knife going down in front of the vertebra. The knife, it means that too much tension in the enthesi of the mediastinum in the posterior part. So this, of course, can generate pain, but this, if it's severe, can generate, alteration of the deglutition of the swelling, so like a dysphagia, okay, heartburn, a lot of other symptoms. So it's important to understand that at the level of the end of the esophagus, there's a connection between the endothoracic fascia, transversalis fascia. So we have a lot of fascia that merge together to coordinate the cardias. So if there is an incorrect tension of the endothoracic fascia, diaphragm, transversalis fascia, this will generate incontinence of the cardias, and it will start to generate a reflux. As we know, a lot of time reflux there's not clear origin. And so when there's not clear origin, fascia can be the real origin of the problem. In fact, it was demonstrated that if you generate a transverse tension in the esophagus, the cardias will dilatate. At the opposite, if you make a longitudinal tension of the esophagus, the cardias will not dilatate. So this is why if you have a tension through the diaphragm, or if you also like the chest is tight, that can lead to a decrease of the compliance of the cardias, and so reflux. So reflux is a very common disorder that you can really fix. I'm talking about patients take 40 milligrams of omeprazole, You treat it, they quit, they don't need any more. But on top of that, don't forget that when we talk about visceral problem, we have to take consideration that the parietal peritoneum is the origin of the problem. In fact, visceral peritoneum does not contain afferent nerve fiber. Visceral pain is caused by involvement of the parietal peritoneum. Also, Platzer say that the only parietal peritoneum is innervated by sensory fiber. So watch out, like if you have like an intense, like a very precise, very shooting pain, that is more related to the parietal part. If you have like a duly not well defined symptom, okay, that can be more visceral. But as you know, the severity of the pain is not related to the severity of the pathology. You know, cancer doesn't hurt until you don't get to the parietal peritoneum, and then it starts to hurt. So visceral fascia is very important, but again, don't forget that we have also superficial fascia. Superficial fascia can be extremely important, again, for multiple symptoms. And talk about disorder of the skin, like a pimple, eczema, okay, dry skin, or hypersudoration, or lymphedema, or, painful cellulitis, or other disorder that can reach to like a Raynaud, complex regional pain syndrome. So all these idiopathic autonomic disorder can be related to what we call superficial fascia, because the lymph nodes are surrounded by superficial fascia. So if the superficial fascia becomes stiff, the flow in and flow out is stuck. So you have a retention of lymph, and so lymphedema, caudal to that. Inside the superficial fascia, we have free nerve endings. So if the superficial fascia become rigid, you can affect, the possibility to have afferent and efferents autonomic. And so you can make a disorder of vasodilatation, vasoconstriction, piloerection, sudoration, and all of that. And on top of that, you can generate allodynia, hyperalgesia. The vein, all the superficial vein, they travel inside a bilamination of the superficial fascia. So you can have varicose vein, tight filling due to alteration of the superficial fascia. Again, don't forget that through the superficial fascia, you have to go with capillary, with nerves, with lymphatic vessels. So if the superficial fascia become rigid, of course, this can collapse, and you can have like a white skin, you can have like a Raynaud, you can have all this kind of disorder. So I want to say that fascia is really important. We are very focused in the deep fascia, but we have all the visceral fascia, like you can see right here, falciform ligament, the omentum that is very important. So all the mesentery, so all these fascia are very important for the mobility and motility of the organ. And on top of that, the superficial fascia is something really new for a lot of people. And that type of fascia is now less important than the other one. So thanks for so much, and I hope that you appreciated this information about fascia.